Today, our presenters are Dr. Lisa Callahan and Professor Heathcote Wales. Dr. Lisa Callahan is a Senior Research Associate at PRA, where she is the team lead for SAMHSA's Dean Center's Technical Assistance for the Adult Treatment Court Collaborative, also an ATCC grant program, and project director for 2 NIJ-funded research projects on juvenile mental health courts. As part of her Dean Center responsibilities, Dr. Callahan provides trauma training to criminal justice professionals. She received her PhD in sociology from The Ohio State University and has completed an NIMH National Institute of Mental Health postdoctoral program at the University of Wisconsin-Madison in sociology and psychiatry. Professor Wales is an associate professor of law at Georgetown University Law Center. He teaches constitutional law, criminal law and psychiatry, and law and social science at the Law Center. He has also been active on committees of the American Psychiatric Association and the American Psychology Law Society relating to the presentation of expert psychological information in the courts. Professor Wales holds an AB from the University of North Carolina and a JD from the University of Chicago. We are very excited to have Dr. Callahan and Professor Wales as our presenters this afternoon. Jessica Myers, who is an associate at the Council of State Governments Justice Center, will be moderating today's presentation. She has extensive experience working with mental health courts across the country, and we are very eager to have her guide the conversation. Let's turn it over to her.
Thank you, Mariana. To begin, we'd like to conduct a quick poll to get a sense of what experience our audience members have working in or with mental health courts. Please take a moment to answer the questions that will appear on the right-hand side of your screen. It will take a few minutes for us to select the results. Thank you, everyone. In terms of our audience today, 19% indicated that they work with an existing mental health court program, 12% indicated that they don't work in a mental health program, an additional 16% indicated that they don't work in a mental health program but work in another criminal justice and mental health collaboration program, 10% responded other, and 43% responded NA. In terms of question 2, 4% indicated that they accept individuals with non-violent misdemeanor charges. 3% indicated that their program accepts individuals with non-violent felony charges. 11% indicated that their mental health court program accepts individuals with both non-violent felony and misdemeanor charges. 6% indicated other, and 22% indicated not applicable. In terms of question 3, the majority of our respondents indicated that they are accepting individuals with a moderate criminogenic risk. 21% indicated that this question was not applicable. 4% indicated that they do not measure criminogenic risk. 8% indicated that they measure moderate to high criminogenic risk. And 2% indicated that they measure low criminogenic risk. In terms of clinical criteria, the majority of our respondents answered that their program accepts individuals with DSM-4 Axis 1 disorders. 6% indicated that their program accepts both Axis 1 and 2. 1% indicated that their program accepts only Axis 2. And the majority of the participants indicated NA. For the 5th question, 15% of our audience responded that they don't work with either mental health, juvenile mental health care program or adults. 12% indicated that they work with adults. 2% indicated juveniles, and 1% indicated both. In terms of our last question, 5% of respondents indicated that their court program was for post-adjudication individuals. 2% indicated that their program admitted individuals pre-adjudication. 6% indicated that their program accepts individuals both at the pre-adjudication and post-adjudication phase. And 72% responded NA. Now I'll turn it over to the director of the CSG Justice Center Courts Program, Ms. Hallie Fader-Tao.
Hi, everybody. Thank you so much for joining us today. We are really looking forward to this session. As resources in both criminal justice and behavioral health systems are becoming increasingly scarce, we are working with folks around the country who are facing increased pressure to plan, implement, operate, and sustain programs based on what works, not just what sounds good, what seemed like a good idea, what you saw someone else doing. As the training and technical assistance provider for the Justice and Mental Health Collaboration Program, we wanted to bring you the best of what's available in terms of what works for mental health courts, understanding that this is not a perfectly straightforward endeavor. There are limits in terms of the amount of research that's been done. Mental health courts have not been with us for a terribly long time. The programs that have been studied formally started in the late 90s. There's also a limit in terms of how many programs are out there. While we are excited to note over 300 programs around the country today in almost every state, these programs serve varying numbers of people, varying populations. They often have changing policies and procedures, changing staff, which makes it difficult to do the sort of controlled experimental studies that would give us precise research that would give you the answer that, for example, a judge should spend optimally 4 minutes and 30 seconds in front of with each participant. I'm just kidding. That's not the sort of precision we're going to be able to offer today. What we are going to be able to do is bring together 2 very talented researchers who have published recently in this area, and we ask them, what does the research say and what does the research leave open in terms of what policymakers and practitioners can do on mental health court design and operation. We ask them to minimize the methodology, keep the math to the side as much as possible, and really try to pinpoint for us where the research gives us guidance on what to do and where, and frankly, to answer where there are still open questions in terms of what mental health courts should do. So you'll hear them talking about process evaluations that describe what's happening in programs. You'll hear them talking about outcome evaluations that talk about the results of those findings. And you'll hear them frankly say, you know what, we don't have a solid answer on that yet. This is what we think we're seeing. So we've organized today's session around common questions that we've received from the field in providing technical assistance in terms of what we know about mental health courts and in terms of what we know and don't know about what works in mental health courts. So without further ado, I would like to electronically clap my hands in welcome for Dr. Callahan and Professor Wales and ask Dr. Callahan to introduce herself and her work.
Thank you, Hallie, and thank you, everybody, for spending some time with us today. I hope we're able to answer some questions and more likely raise some questions that you might have about mental health courts. In addition to what Jessica mentioned at the outset of my background, the studies that I am going to be primarily referring to today, the first one is the MacArthur Mental Health Court Study, which was funded by the MacArthur Foundation, and frankly, it was an extraordinarily expensive study to do, and I don't think a federal agency would have been able to do that. It took place over about a 5-year period of time, and it involved 4 different mental health courts. And I can give you more information about that at a later time. I'm also, toward the end of the webinar, going to talk a bit about juvenile mental health courts, which are really the new kid on the block. And we have an NIJ grant that we're winding up right now that compares 2 juvenile mental health courts. We do 2 evaluations in 2 sites. And lastly, a lot of, especially the more practical applications that the questions include, really have become very informed and have really helped me really distill my understanding of mental health courts is the work I've been doing the last 1.5 years with the GAIN Center, which is here at PRA. I oversee the 11 Adult Treatment Court Collaborative grants through SAMHSA. And there's a lot going on in those grants that I think really can help mental health courts do a good job and be sustained.
Hi, Jessica. This is Advocate Heathcote Wales. I've been involved teaching law and psychiatry now in law schools for 45 years. Interested in civil commitment and problems of the mentally ill defendants in criminal court. My most recent involvement in doing studies, which I'll be talking about some today, is to do a outcome study of the Washington, D.C. misdemeanor mental health court, looking at the first 2 years of its operation in 2007 to 2009 to see the extent to which it was producing reductions in recidivism. I've been studying mental health courts in particular for roughly 10 years, visiting as many as I can and talking to staff and judges and trying to learn more about them that help inform empirical research.
Great. Thank you, Dr. Callahan and Professor Wales. As Ms. Bader-Tau mentioned, today's webinar will be a conversation centered around key mental health court design and implementation questions that reflect the needs of the field. The questions that we will be focused on today are: do mental health courts reduce recidivism? What kind of defendants produce the most favorable mental health court outcomes? That is, for whom do mental health courts work? What kind of data should mental health courts collect? Under what circumstances should mental health courts use jail as a sanction? What can mental health court teams do to facilitate the success of participants? And lastly, based on your research and work in this area, what advice do you have for courts to help sustain themselves beyond a federal grant? Okay, let's jump right in and get started with our first question. Do mental health courts reduce recidivism?
This is, without question, the most important issue that people who want to start mental health courts are asked is, is this going to reduce recidivism? Is it going to make our community safer? And as the bubble says above my head there, in a word, they do. And what's interesting, I think, about that conclusion is that regardless of when the study was done, how rigorous the methodology is, almost every one of the studies has concluded that mental health courts do reduce recidivism. And while that can be fine-tuned and has been fine-tuned, I think that really is a message that is clear from all of the research that's been done over the last 10 years. I mentioned in an earlier slide the MacArthur study, and I'll be referring to it as that. That study where really to date is the most scientifically rigorous research that's been done on mental health courts. And the reason is, without getting into too much of the methodology, it included 4 sites. It had a pre- and post-design. We included a comparison group. And also these courts all included felonies and misdemeanors. And just a little bit about the comparison group. A lot of mental health court evaluations study their own participants, which is completely understandable. What we were able to do in the MacArthur study was to match the mental health court participants with similar people in the jail who had mental illness, similar kinds of crimes, similar demographics, and for one reason or another they weren't in the mental health court. They were all eligible for it, but they for one reason or another, were not enrolled in the mental health court. We found, as the conclusions state very clearly here, we found that the annualized arrest rate was significantly lower for the mental health court sample after they enrolled in mental health court than it was for the similar jail treatment as usual sample, the comparison sample. And this was true also for the incarceration days. So in a simple answer to the question, do mental health courts reduce recidivism, the MacArthur study found that it does. And what we did is we used a lot of fancy statistics to control for characteristics, diagnosis, crime, time at risk that they were in the community to reoffend, and we still found a very strong impact of mental health court participation on rearrest following release from jail. Another, maybe to some of you in the audience, the most important question, but to others, maybe public policy people, it's not. A really important goal of mental health courts is to increase treatment services to mental health court participants, because there's an assumption that mental health court participants aren't getting the treatment that they need and that the services aren't being provided. So we also looked at treatment. And I could just as an aside, treatment's a very hard issue to study, and because there's so many providers. At least in the justice system, there's one provider, and in the treatment community, there's many. But we looked at the type of treatment and the numbers of treatments that the mental health court people received, both before and after enrolling in mental health court. And we found that in the 12 months prior to their mental health court enrollment, they had more crisis episodes. In other words, more visits to the ER, or if a community had a crisis center where they would take persons with mental illness, more crisis episodes. And we also found that they had more therapeutic treatment episodes prior to their enrollment in mental health court. So in other words, they're already known to the system. They're more likely to be known to the treatment community than other persons with mental illness who become justice involved. After mental health court enrollment, we found that their crisis episodes declined. In other words, the most expensive kinds of treatments that they are encountering have declined. They have more intensive treatment episodes. Now, that includes residential care, detox, and if there's some kind of transition psychiatric inpatient, it would include that as well. And they had more therapeutic treatment episodes. That would be your standard community treatment, group therapy, et cetera. In other words, there is a shift in the type of treatment that mental health court participants get following enrollment in mental health court. And in many cases, it's away from the most expensive type and focuses instead on those that are provided in the community. And another really important part of what we looked at is that the time to treatment, in other words, once they're discharged from the jail, when do they first have their first treatment episode, and it is much more quickly, I mean, literally by almost a month and a half more quickly than it is for similar jail defendants who don't enroll in mental health court. In other words, they're being discharged and they're immediately getting into treatment, whereas other inmates who have mental illness who are in the jail are being discharged from jail, and it can be up to 6 weeks was common for someone before they had their first mental health court treatment episode in the community. another study that has been, I don't think has been published in, say, in journals, but the final report has come out, was an NIJ-funded study done by the Urban Institute, and they looked at two New York City mental health courts, one in the Bronx and one in Brooklyn. And I put pre-post in quotation marks because they didn't collect all the same pre-mental health court enrollment data, but they did have some pre-enrollment data that they were able to get. And they had a treatment as usual jail sample as well. And actually, it was a very enviable sample. They were able to match person to person in a large New York City database to match their subjects to a comparison group. The conclusions from their study are similar to the MacArthur study. They found that post-entry rearrest rate was significantly lower in the Brooklyn mental health court sample than in the treatment as usual sample. And it was lower in the Bronx, but it was not quite statistically significant. It was in the right direction, but it didn't reach the threshold that scientists say it has to reach for us to conclude that that was, in fact, lower. And the same was true with their post-entry reconviction rates. It was significantly lower in Brooklyn, and it was lower in the Bronx, but not statistically significant.
Professor Wales, based on your research, do mental health courts reduce recidivism?
Yes, they do. At least in the short term. We don't have studies ranging out multiple years after mental health court. Most of the outcome studies that we've done, that have been done so far, measure recidivism post-entry, as Dr. Callahan has described, so that you have a mix of arrests that occur during mental health court supervision and some that may occur after they've departed mental health court. There are at least 5 studies that I know of, including my own, that measure arrest post-exit, the longest follow-up periods being 2 years post-exit. And all of these are finding statistically significant reductions in recidivism after they've left the supervision of the mental health court. The D.C. study, which is with Virginia Aldershay Hyde, a distinguished sociologist at North Carolina State, and Bradley Ray, a criminologist, is a study of a misdemeanor court that also has a pretrial services agency that manages people who are out on pretrial release. And it's a pre-plea, so it's people are, if they successfully complete mental health court, they get the charges dropped. And it's a relatively short mental health court. After they're accepted, they spend 4 to 6 months, sometimes a little bit longer, in the mental health court. So one of our interests was, can it work if it's done on a relatively short-term basis? Most of the other studies involve longer terms in mental health court. It's pre-post, so we're looking 2 years before their key arrest and 2 years after they leave mental health court. And the comparison group are people who are likewise being case managed by the pretrial services agency, who also have severe mental illness but are not in mental health court. So what we're trying to isolate there is the distinction between receiving mental health services, which could be done without a mental health court, and being in a mental health court as well as receiving the same services. Both groups, the comparison group that was being supervised by pretrial services and getting mental health services, and the mental health court group had significantly fewer arrests 1 year post-exit. The graduates of mental health court had significantly lower percentage, and a significantly lower percentage arrested than the comparison group and the mental health court non-completers, those who opted out after a while or got sent back to criminal court. And of those arrested, the mental health court completers had fewer arrests and a longer time period before they got arrested. We're still running the 2-year data, but the 1-year data pre-post and comparison group is in this article that's being published this year. The principal difficulty that all of us researching this question have is in coming up with a comparison group that is really the same as the mental health court group. That happens because the selection criteria for acceptance in the mental health court may be in ways that we're not understanding, picking out the people who are most likely to succeed and leaving in treatment as usual those who are less likely to succeed. And there may also be volunteerism, those agreeing to mental health court more willing to change. There's still, of course, the question of even if they are volunteering, would they have changed if they didn't have the help of the mental health court? I want to emphasize that we don't know what it is about mental health courts that's working. We have a lot of theories. I mentioned 2 here, that attention to criminogenic variables may be supplying a lot of improvement, and procedural justice, which I'll talk about more on another slide.
Great. Thank you both. Moving right along to our next question. What kinds of defendants produce the most favorable mental health court outcomes? That is, for whom do mental health courts work?
This is one of those questions when we've discussed it in talking about the webinar, that it's really important to follow the entire part of this, because we don't want people to come away with sort of misimpressions about what we're concluding here, and I'm speaking for myself here. We found in the MacArthur study that the rearrest rates, when I refer to them as being lower, I'm only presenting findings that were statistically significant, not trends that weren't, because we had a large enough sample that if something was happening, we would measure it. We found that rearrest rates are lower for mental health court participants who graduated from the program. And that may be an obvious statement, but what it really does speak to what mental health courts measure in terms of your own data, and we're going to talk about that a little bit more. But if you only study graduates, you are really cherry-picking your participants. And so really, in order to study what the mental health court is doing, you need to look at everybody who's enrolled in the program from the first day. They also had lower pre-arrest and incarceration rates, meaning before they came into court, they had less of a criminal record, and they were more likely to have been engaged in treatment when they came into the mental health court. We interviewed them immediately when they came into mental health court, so that was our baseline interview. And the same is true for incarceration rates. All of what I just said applies to the mental health court participants, but the next 2 really speak to what kinds of issues would come up in a mental health court that you need to pay close attention to. People who haven't used illegal substances in the past 30 days are less likely to be arrested, and people with bipolar disorder are less likely to be rearrested. Important is that we found no demographic characteristics related in any way to whether or not they were successful or graduated or were rearrested. So sex, race, age, none of that mattered. In the Urban Institute study that I mentioned, they found that older mental health court participants were less likely to be rearrested, and as we found also, race and sex don't matter. And they're more likely to be people who were first arrested for violent offenses. In other words, if that's the target offense that brought them into mental health court, they have lower rearrest rates than people who came into mental health court on a property or a drug offense. So in terms of selecting cases to come into court, the issue of criminal risk and the crimes they've committed the research seems to point in the direction, we found this also, is that the more serious the offense, the more likely they are to graduate from mental health court. And similar to our findings, the NIJ Urban Institute study found that in terms of diagnosis, people who had a substance use disorder were more likely to be rearrested. We also, I want to focus a little bit here on co-occurring disorder, that is people who have a substance abuse and mental health diagnosis. In general, people who come into the justice system with a co-occurring disorder have more challenges than people with either one or the other. And mental health courts and drug courts alike see a lot of people who have co-occurring disorder. They may not know that up front, but after a few months of some challenging times, they may realize that they have they need to deal with the co-occurring disorder. They tend to have lower education, were younger at first arrest, had more arrests, but no demographics made any difference at all in terms of who was successful and who was rearrested. Not surprisingly, they were more likely to come in on drug offenses, but there's also no difference in their primary diagnosis. So we found whether they had depressive disorder or schizophrenia, another axis one, didn't make any difference at all. It was the fact that they had a co-occurring disorder that was the important factor. Part of the reasons why people with co-occurring disorder are viewed as being or seen as being most successful in mental health court is they're judged as being less likely to comply with conditions. That includes everything from judicial orders to taking the medications. Now, this was an impression. These were impressions from the court administrators. There was not an objective measure. We don't know if, in fact, they objected to medication, but this was the impression from the court coordinators. They were also more likely to have their mental health court hearings in jail, meaning they come in an orange jumpsuit to their status hearings, and they're more likely to be sanctioned, across the board sanctioned, but specifically they're more likely to receive a jail sanction, which we're going to talk about a little bit later on. So this group then of people who I'm mentioning, mental health court participants who have a co-occurring substance abuse disorder, they're more likely to be rearrested. They spend more time in jail. They're more likely to have their mental health court program terminated, or they're more likely to still be supervised at 12 months, meaning that there's a need for continued supervision, perhaps because they've had a number of jail sanctions. One aspect that we've looked at in the MacArthur study is trying to kind of drill down and see what the costs are, whether savings or additional costs involved with mental health courts. And I'm going to talk a little bit more about that later, too. But we did find that people with co-occurring disorder are real high users of treatment and of the justice system. We found that for participants who didn't have a co-occurring disorder, their costs went down in the years after they were in mental health court. But for those who, over half did, but for those with a co-occurring disorder, that happened with only a third. In other words, 2/3 of them either stayed the same or went up. And just as a measure of how the extent to which people in mental health court have a co-occurring disorder, the Urban Institute study found that 2/3 or more in both the Bronx and Brooklyn of their participants had a co-occurring axis 1 or 2 diagnosis and a substance use disorder. So most people in many, many courts, the majority of people coming into a mental health court do have a co-occurring substance use disorder.
Dr. Callahan, I understand from these findings that the populations with co-occurring disorders struggled in the mental health courts that you studied. Does this mean that mental health courts should avoid admitting people with co-occurring disorders, or simply that they should make sure that they have the appropriate treatment and supervision options in place to handle this subpopulation?
I mean, that's really an excellent question. I think it really gets to the heart of the matter. My first recommendation would be that mental health courts need to screen and assess for co-occurring disorder. Many don't. And a couple of years ago, we did a seminar with CSG, or we did a presentation with CSG, and we talked a little bit about this. I think it was down in Baltimore. That it was surprising to us how many courts don't even record. So they're clearly not screening or assessing for co-occurring disorder. But it's very important to do. As you can see from the Bronx and Brooklyn, 2/3 of their clients have that. So that would be my first statement on that, is you need to screen and assess. Then, exactly what you said, you need to make sure you have the right treatments in place so that people who have a co-occurring disorder can be successful and they can get hooked up to the treatments that they need and that we know from evidence are successful in treating people with co-occurring disorder.
On the same question, the DC study that I mentioned before found that people who graduate are much more likely to have reduced recidivism. Age made a slight difference, but statistically significant. Older people did better. People who had fewer arrests in the year prior to their key arrest did better, and people who had fewer arrests while they were under the supervision of mental health court did better. I think we skipped a slide. I did not. Okay. We in the end, we don't really know and won't know until we sort out the elements of treatment and services being offered in mental health court programs. That we're having a positive effect. That is that depending on the resources that are available to a mental health court for coordinated treatment, for example, of co-occurring disorders, the mental health court may or may not be effective for severely mentally ill persons with substance abuse. The question I got from one of the prosecutors when we were doing the DC study was who can be predicted to be successful mental health court clients. And of course what the prosecutor had in mind was the idea that they would screen out people who had lower success rates. But it turns out that even among the groups that are less likely to improve their recidivism through mental health court, many do succeed. Many are capable of success in mental health court, and many have graduated and done better. But the other thing that needs emphasizing to screeners is that there's a kind of dynamic process that goes on in the evolution of a mental health court between the court and providers as they adjust their own practices and their own treatments to the clientele that they're receiving. Every mental health court I've visited has had this kind of dynamic process going on, and so at least from the point of view of somebody in a research position, we would love to see more people, more kinds of clients getting into mental health court so we can figure out whether the mental health court of a particular community and the service arrangement of a particular community can do something positive for that group. So it's a very treacherous question, who does, what predicts the most favorable outcomes. We know from the courts that have been studied the answer to that question, but those courts are not fixed in time in the kinds of services that they provide and the kinds of treatments that they attempt. And what we really need to do is to sort out differences in mental health courts according to what sorts of treatment and services they're actually providing to see what's effective with what populations or what subpopulations of persons with mental illness. Clearly, a starting point is people with co-occurring disorders. We have plenty of information empirically to suggest that people with severe mental illness on axis 1 who have a co-occurring substance abuse or cluster B personality disorder are going to be more likely to show up in the criminal justice system. And to the extent we can treat those conditions, mental health courts should be addressing them.
Great. Thank you, Dr. Callahan and Professor Wells. We're going to move right along into our next question. What kind of data should mental health courts collect?
I love data. I'm a researcher. I love data, but I can say that I think many programs in many places collect too much data, which may surprise you to hear for me to say that. But I think it's before you decide what kind of data you want to collect, I think the first thing you need to address or question you need to ask from your team is what is the purpose of it. Sometimes you're required to collect data because you have grants or perhaps just for internal purposes, but that really then dictates the kind of data and what data you're going to collect. Second of all is, do you have the resources to collect data? You don't want to collect data sporadically. You want to collect it consistently, preferably with help from an outside researcher. And use a college or a university. They often have graduate students who are looking for internships and other kinds of practical experiences. Often you don't need to pay them, which makes it even better. If you can use some web-based programs that already exist, but you need to have program staff who reliably enter the data, not just when the evaluation is coming up. The other, what are the outcomes that you need to measure? And this may be dictated by the community that you're in. Do you need to measure whether or not recidivism has been affected? Do you need to measure what your graduation rates are? That's often the first question someone will get. Well, what's your graduation rate? I'm not sure that's the best measure, outcome measure, because there's a lot of reasons why people don't graduate, and not all of them bad. And also, do you need to measure if there's been an impact on treatment services and what kinds of treatment? And so really know what your outcome measures need to be. And then basic information about your participants, about who's being referred. This is a question that is often overlooked. We often just start picking up when people are in the court, and then we start collecting information. I think it would really add to the field if courts began collecting data on who's being referred and why they're perhaps not enrolled in the court, because that might speak to some of the issues that Professor Wales mentioned, sort of cherry-picking people. We would know that. And it also, at least on some of the other studies I've looked at on mental health courts, in particular juvenile mental health courts, it could start to address the disproportionate minority contact concern that some treatment courts and diversion programs have been people have been suspicious of, that there's that the referral process perhaps has some bias built into it. But I've listed here basic information that I would recommend that courts keep. As I said, if you can start with referral, not just with enrollment, I think that's positive. There are some programs that are pretty easy that you can just adapt and enter the data yourself. Process information is important, especially for self-assessment, and that's sort of your program evaluation part. Who's doing the referring? This varies sometimes weekly, I've found in some courts. Sometimes there are some referral sources that there's a blockade and you might need to know why. How long does each step take? Sometimes it takes months for someone to be referred and then enrolled in mental health court. That is very discouraging to people who agree to go into a treatment program, oftentimes post-plea, often with the promise that they're going to receive services, and then there's a long period of time before they actually start receiving the services. So that's a good place for self-examination. And then basic questions about who the team is and what the hearings look like, and examining steps and phases. Not all mental health courts have phases. That might be a surprise, but not all do. And that is often a reflection of the philosophy of the judge and the team. And I think lastly, I would, again, talking about what kind of outcomes. In mental health courts, participant outcomes are really very individualized. They don't move along they can't move along in lockstep in a way that people might be familiar with from drug courts. like so many months or so many days or so many checks that they pass on to the next level. That isn't necessarily going to work so well in mental health court. And then also speaking to what Professor Wales mentioned is we do not have very good data on post-enrollment completion follow-up, meaning once someone graduates or terminates or is, it leaves the mental health court supervision, if there's a way of maintaining some information about them post mental health court, that would be really effective outcome data to collect, if possible.
I would concur with Dr. Callahan's suggestions. The business about reliable entry of data is really, I would just re-emphasize, is just hugely critical. It does no good to collect data if it's sporadic or if people are following different rules about what to enter and so forth. I also wanted to emphasize Dr. Callahan's point about after they've left mental health court. If indeed the mental health court has a system of keeping track of alumni, as it were, it would be hugely useful. It could be hugely useful to the court itself as well as to researchers like us to know how they fare in their functioning and in their interaction, not just their interactions with the criminal justice system, but their functioning more generally after they've left. That is, how much of the mental health court experience sticks and carries through to their return to the community. Again, we're in this awful situation of knowing that mental health courts can work, that they have worked in a number of situations in reducing recidivism, but not knowing exactly why, because the mental health courts are each a little different in the kinds of treatment and services provided and their organization. So we've been trying to figure out the causes of offending by seeing what stops it, just as we've proceeded with illnesses like schizophrenia, where we still don't know the causes, but we are developing theories by seeing what works in ameliorating symptoms and the like. And so again, I want to emphasize the recording of the precise elements of treatment and services that are being provided to mental health court participants. What kinds of therapies are being offered for what kinds of problems in their lives, and trying to tie that to outcomes in recidivism and the like. And we have precious little information about that currently, in part because it's a moving target, because the mental health courts are under constant change, but also because we haven't figured out good ways to record that information. So that, for the long term, that's really a central interest in terms of data collection. I would also mention feedback from the mental health court participants themselves. Now, of course, you can't go in the first day of mental health court and say, do you like mental health court? Because they know that they need to make a good impression to eventually get out of mental health court. But at some point, when they're no longer connecting their answers with their status in the court, it would be useful to collect information from participants themselves, both on court processes and on the treatment protocols, to try to flesh out the degree to which you're successfully reaching your plans and the degree to which you're not. One last item that I probably don't need to tell anyone in this audience is that we're all, the researchers are all dreading the oncoming DSM-5 in May, because it's going to be a whole lot harder for us to compare studies done under DSM-4 diagnoses with studies done with DSM-5 diagnoses. I don't think I would press on any mental health court the need to do this, but certainly from a research point of view, we'd love to know how those people are diagnosed under both regimes.
Thank you, Dr. Callahan and Professor Wales, for your recommendations around data collection. We're going to move right along to our next question. Under what circumstances should mental health courts use jail as a sanction?
One of the primary questions that I would recommend mental health courts to think about when they're considering their sanctions, considering their structure of their phases, and is to really ask whether jail is a viable option as a sanction. That's, for some, it's a philosophical argument. One of our 4 courts in our MacArthur study never used jail as a sanction for any of the mental health court participants in the study. I mean, they were all the mental health court participants. Did not use it, did not believe in it. And their outcomes were equally as good as the other counties or the other courts. So it really, in many cases, is a philosophical position that starts with the judge and with the team. It's not an absolute that jail has to be on the table as a sanction. And another philosophical or practical consideration is that, and this really, I'm coming at this a little bit from my experience with the Adult Treatment Court Collaboratives, which are blended courses. Mental health courts are not drug courts for people with mental illness. The essential elements of mental health courts don't mirror the I can't remember what they're called in drug court, the 12 or so criteria of a drug court. What's that?
The 10 key components.
Well, I know, but the drug court has like 12 that are, don't they? Anyway, but the basic difference is that mental illness is not a crime, whereas having illegal substances is. So the condition that brings someone into one of the treatment courts is substantively and legally different, and therefore the courts need to look different. So for communities that are planning courts and are just going to make a mental health court an adjunct to their existing drug court, I would encourage them to take a step back and examine that a little differently. Because one of the most important questions that teams need to ask if someone doesn't comply with a court order is why didn't they? And that is going to vary clearly by diagnosis, by access to treatment, by whether they're symptomatic. I mean, there's a lot of or they were just being ornery and decide not to comply with the court order. But there are sometimes some very legitimate reasons why someone has not complied, and using jail as a sanction for noncompliance might not be the best route to go. We looked at we looked at jail sanctions in the MacArthur study and all sanctions, but we looked at jail sanctions in particular, and I'm going to talk a little bit about those in a minute. But I think the team has to have a really clear understanding and agreement on what the objectives are if you have graduated sanctions, and decide whether or not a jail stay will obtain this objective. It may be in your arsenal of sanctions, but will it do what you want it to do? Many people who are in mental health courts, this is not their first time in jail, and often not their second or third or fourth time in jail. Jail may not instill the kind of response that it might with someone who is a new person to the criminal justice experience. So there needs to be an agreement, and the treatment staff or the treatment team members and the supervision team members need to be in agreement on that. So there needs to be a team perspective. And then there are practical considerations. I've talked with people who run, especially, for example, a mental health court that deals primarily in misdemeanors. There's no room at the jail. It's not even a practical option for them to send someone to jail for a sanction. And there are other practical considerations. Is there someone to send them, to transport them? In some rural areas, transportation is a huge issue, and it may not be practical to use jail as a sanction. And are there other options? And if you do use jail, what do you have left? What's left in the graduated sanctions? We looked at sanctions, and we looked at jail sanctions, and we found that they were used in about 20 to 30% of the cases in the mental health courts, with the exception of the one that never used it. The other three used it in about 20 to 30% of the cases during the time someone was in mental health court.
The problem with jail as a sanction, at least initially, is we don't have any empirical evidence showing it to be effective in reducing recidivism in this population of folks with severe mental illness and often co-occurring substance abuse. As Dr. Callahan mentioned, it may be a question of philosophy at the core of the participants in the team, and of course we always go to philosophy when we don't know the empirical answer. But the whole reason, one of the main reasons, at least, for mental health courts is that folks with severe mental illness make for, at least from the custodian's point of view, lousy prisoners. That is, they stay a long time. They're not easy to manage, and they don't get better through the jail experience. So it seems odd to be reverting to jail in a mental health court, or at least it should be exceptional. One court I've looked at in Idaho Falls started out using jail sanctions early on, carrying that experience over from what worked in drug court, and has gradually moved totally away from them. They may give out jail sanctions, but they suspend them and substitute various sorts of more positive experiences as a way to work off your jail sentence, instead of working in a soup kitchen or a variety of other kinds of things that are geared toward instilling in the client some idea of being of some use in the community, of being interested in something other than his own condition, and in connecting with the law-abiding community and being helpful to it. So there's a lot of room for imaginative work here in coming up with creative sanctions that don't actually involve putting on the jumpsuit and going to the jail cell. The other thing is that if they are using jail sanctions, it would be a pity if the jail sanctions kept the client away from their service meetings and their therapy sessions. It would make more sense to have them on day release for attending the various requirements of the mental health court program, even if they're spending the night in jail. My concluding point here is really that the whole point of mental health courts is to emphasize cooperative problem solving as opposed to adversarial blaming, which is what happens in traditional criminal court. And jail time tends to contradict and confuse this message. It tends to bring back the model of adversarialness and blaming, in part because of what Dr. Callahan mentioned about so many of these people having prior jail experiences.
In the McArthur study, we did look at, we compared the group who received jail stay as a sanction with the others, and here I present some of the characteristics, and it probably doesn't surprise you to know that they had more symptoms at their 6-month interview. We interviewed them at baseline when they entered the mental health court, and then 6 months later, and still at 6 months they were having more trouble with controlling the symptoms of their mental illness. They were more likely to be arrested for a drug offense, least likely for violent offenses. Again, here's the violent offenders seem to comply the most and meet the court objectives more than those who had the what we might call less serious offenses. They were more likely to be homeless, both when they came into mental health court and they were homeless for more days. And this is one of the reasons I think it's really important to, if possible, to assess risk for homelessness, because it makes it very difficult for someone to comply with treatment when they're homeless, and it exacerbates symptoms, et cetera. And people who have had a jail sanction really fit into that category of people who've had more arrests, more incarcerations, have used more drugs more often. And the last point I made there, we did ask them about their experiences with whether they thought they would be sanctioned if they didn't comply with conditions. And the group that did receive a jail sanction were the least likely to think they'd go to jail if they violated their conditions. So they didn't have a clear understanding of what might happen to them, what the possible sanctions were if they didn't comply.
Dr. Callahan, do these findings suggest that jail is an appropriate sanction?
Oh, that's a tough question. Far be it from me to tell clinicians and probation officers and judges if someone needs to go to jail. However, with what Professor Wales said and with what we found in the MacArthur study is it often undercuts the intent of the mental health court. And in the interviews that we've done and focus groups that we've had, often it seems jail is used when the team becomes frustrated with not having found the right carrot to get someone to comply. And I think that with better screening and assessment up front, whether it's for trauma and or co-occurring disorder, that compliance is going to go up, especially if people are hooked into appropriate treatments. And I'm sure people have questions about treatment and accessibility of treatment. And, whether there's trauma-specific services available, whether there's co-occurring treatment available, all of that will presumably have a better impact on compliance, and therefore jail wouldn't need to be a sanction. But I don't think it can be understated what Professor Wales said. A jail stay is very disruptive. It's disruptive to therapy in the community, groups, community service, school, vocation, housing, maintaining their social networks if they're starting to reunite with family. Going back to jail disrupts all of those positive steps. And sometimes it's one serious misstep that will send them back, but it often has the effect of erasing all the positive that has been accomplished up to that point.
Great. Thank you both. We're going to move right along to our next question. What can the mental health court team do to facilitate the success of participants?
This is a little repetitive to what I said before, but I think it's really important for the treatment team to set individual goals for each individual participant. There's no cookie cutter. Everybody's at a different place with their mental illness and with their recovery and their readiness for recovery, and to set realistic steps in achieving those goals. And part of that has to do with whether you have the services available for the individuals that you're bringing into the mental health court. Consistency in the team. And I don't mean consistency across all participants, but the team speaking with a common voice about what they think the core of the issues are and how they're going to go about dealing with those issues. The third point, and this is something which is a whole other webinar, effectively integrating peers into the team and in the service delivery, such as hiring recovery coaches, having peer mentors run groups, having graduates of the mental health court, for example, do orientation and explain the mental health court to people who are considering it, have them sit with people who've been offered an opportunity to go into the mental health court, have them sit through the status hearings and have a peer explain to them the process. It takes away some of the mystery. They're often the best advocates for the program are people who have graduated from it, and more states are creating paid positions for peers to work in justice positions. So this, I think, is a really great opportunity for mental health courts to integrate peers into their team, and also to revisit their policies. Through those data that we're talking about, you should be collecting, revisiting. Are our policies making sense? Do the procedures make sense? Is our court working? Because if the court's working, it's going to be working for the participants. This next point, use data to inform your internal review. Sometimes we provide redundant services, and that sometimes is because, to use the overused analogy, sort of the silos, or maybe that's a metaphor, but the silos of services, we may be working at cross purposes. Do we have the resources to match our participants? If not, how can we get those resources? It may be by identifying new resources and partners in the community, which I'm a big advocate of as well. Go out and sell your program. Take advantage of free training that's provided. SAMHSA provides what's called SOAR training. Again, I can give you more information about that at another time. That's hooking up people with benefits that they're entitled to. And build allies across the entire system, not just in the justice system. Know people in the emergency room. Know people who work in the EMTs, work in crisis, not just the jail and the treatment providers.
This is where I wanted to talk a little bit about the idea of procedural justice, which it seems to me is one of the factors that may explain, this is just a hypothesis for which we have some evidence but not a great deal, which may explain success in mental health court of the participants. The idea of procedural justice was originally set up in contradistinction to deterrence theory, where the criminal law seeks to deter people by imposing pain if you do bad, and making you think twice about whether you really want to do bad. The procedural justice theorists have a different idea about how you get people to obey the law. They think that you get people to obey the law by getting them to buy in voluntarily at a point in which they see the commands of the law as being legitimate, as being in their interest. And a large part of the buy-in that is suggested in this literature occurs because through the way the quality of interpersonal treatment that occurs in the court system. In the typical misdemeanor or low-level felony case, the court system is just a blur to most defendants. The attorneys do all the talking, and they have no clue about or very little clue about what's going on and why. Here, the idea is that that we're engaged in a collaborative process in which the clients, the participants, are being encouraged by the way they're treated in the court to sort of buy into what the mental health court program is trying to sell them by way of changes in behavior and the like. So key elements are to treat the participant with respect, to listen as well as to talk to them, talk with them, not to them or at them. Take them seriously as a partner and treat them as a partner in the recovery process, and try to indicate that that's the attitude of the treatment team as well, that we're partners. And indicate all directives and obligations clearly, explain them, be very transparent about everything and very clear. Try to reinforce the notion that participants present is their choice. Now, it is technically their choice in that they have to say yes, so a lot of them come into court not knowing what they've agreed to. Sort of letting them know that it's still their choice, that they are free to withdraw at any time, and that if they're staying there, it's because of their choice, that they're responsible for the consequences of their choices. And then this fourth point is constantly attempt to discern those aspects of participants' behavior for which they can reasonably be held responsible. What you're trying to do is to a group of people who often feel as though the winds of fate are buffeting them from one place to the next all their lives, is to indicate to them that they do have the power to control aspects of their lives. And to the extent they don't, the treatment team can provide them with assistance, whether it's budgeting or how to look for a job or any of a number of things. And that's a very delicate calculation to make. It's a very difficult calculation to make. But as they proceed through the program, try to figure out what can we hold you accountable for and make it clear to them. And what are they having trouble doing on their own that they need assistance for and offering that assistance. A lot of these folks are not used to being taken seriously by other people, and when they are taken seriously by the mental health court team and by the judge, it can make a huge difference in their willingness to sort of buy into what the judge and the team are suggesting that they do differently. Lastly, strive for consistency and cohesiveness among team members. Dr. Callahan's point about working across purposes, we don't want that. There has to be a lot of communication between team members and a lot of effort and consensus on how they're going to approach a particular case. A lot of what mental health courts do is help to get the various balkanized, distinct treatment and service providers that touch on this group to be on the same page. That's an important aspiration of mental health courts, both to make the treatment in mental health court more effective and also to possibly reform the way services are delivered to those who are not already in the criminal justice system.
Okay, great. Thank you both. We're going to move into our last question of the day. Based on your work and research in this area, what advice do you have for courts to help sustain themselves beyond a federal grant?
I think the most important task at hand is for you to know if your state is participating in the Medicaid expansion under the Affordable Care Act. As of about a week ago, half the states were. Two additional were leaning yes, 3 no, and 14 had explicitly said they were not participating. And the reason why this is really important is because justice-involved people are not excluded from Medicaid eligibility, which means that jails and community providers are going to be able to be reimbursed to some extent for services that they're providing. And this is really, really important. Not all the states that are participating have decided what their essential services are going to be. Join the discussion, become the expert, be the one who can demonstrate that these are services that are needed and services that can be reimbursable under the ACA. A very common claim that mental health court and drug court advocates make is that they'll save the community money. I would avoid making that claim, largely because we don't know. I think it's safe to say that they save money for some, they cost more money for others, and stay about the same for probably the largest proportion of people. And recent research on drug court shows exactly the same thing. But there are ways to show that despite that, or I would just take it out of the equation altogether, is find the key allies at every level of government in your community. And judges are really good at this. People listen to judges. They take their calls and have the judge advocate for the program. Don't wait until there's bad news to run sort of a Band-Aid approach. Do good publicity. I know this sounds maybe outside of your comfort zone. Highlight your program with success stories. Have people who've graduated be a feature in a radio show or a television, or if your community has a web page. Create an informative guide about your program that looks good. Again, have a high school student to do this as a project for you and distribute it. Hand it out to your legislators. Hand it out to people who make the decisions that decide whether or not you get funding, and just beyond your mental health board, at the local government and the state government. Go to community places and promote it. Invite people to your status hearings. Take people on tours of treatment facilities. Most people have absolutely no idea what a community treatment place is like, where people get treatment. They have sort of old-style views of that. And explain to everyone when you have the opportunity why your court is an integral part of the community. A really important task that you can do, whether you're in your planning stages or you're just revisiting your court at this point, is identify at least one partner at every intercept of the sequential intercept model. And if this is unfamiliar to you, what the SIM is, you can contact me and I can give you information on it. These are people who are directly affected by your court program. By cutting down on crisis services, you're making life better for people in the ER. Have your community public hospital on board. Police are usually on board from the get-go because they've had lots of training around dealing with people with emotional disturbances, is what I think they call them. So be creative in who's part of your community. It goes well beyond the justice system and the treatment system that you're accustomed to. You have many allies who would be willing to go to bat for you and for the sustainability of the program. What would happen to them if your court went away? I know nobody wants more meetings, but convene your stakeholder group on a regular basis, say twice a year. Have objectives, have an agenda, take minutes, publicize the information, have them report out, have tasks. Again, you can have a local college or university be the evaluator of either your court or your work group and to be sort of drive it along. Public administration graduate programs like to do these kind of projects. But by taking it seriously, your stakeholders and your allies are going to take it seriously, that you're meeting on a regular basis and asking for their input and their help, and that you implement that when it's possible.
Great. Thank you both. We will now begin the question and answer session. I will moderate the questions coming in from the audience. We will do our best to answer as many questions as possible in the time remaining. The first question is for you, Dr. Callahan. A participant asks, we have an existing mental health court and some team members advocate jail as a place to stabilize mental illness or as a holding place until there's a treatment plan. Is there a difference in the effectiveness of jail for co-occurring disordered clients in a mental health court?
I'm going back to the comment that there isn't a treatment plan to put them in jail while they formulate a treatment plan. I'm assuming that's a revision of the treatment plan. A lot has to do with what you have available to you in your community. I mean, it's not all communities are resource rich. Not all communities have temporary housing that would have greater supervision. Perhaps jail is the only option. I think this goes back to the philosophy of the team and examining if there isn't another option available. If it's important for people to not use jail as a sanction, then develop that resource. And I know that sounds like pie in the sky, but communities do it all the time without resources because they're committed to it. And work with the jail. I'm sure the jail doesn't want to, as Professor Wales said, I'm sure the jail doesn't want for people to be coming back there as a place to stabilize someone with mental illness. I would strongly encourage the team to, as I think Professor Wales said, be creative around what the options are.
Thank you, Dr. Callahan. The next question is for you, Professor Wales. The participant writes, we have a lot of defendants that are repeatedly arrested and found incompetent to stand trial. Are any jurisdictions focusing on these offenders? Are they included or excluded from the courts that you have studied?
Boy, that's a tough one. If they go through the procedures for determining competency to stand trial and are found incompetent and have to go through restoration of competency, they're going to be off on a pretty long frolic and detour in most jurisdictions, a frolic and detour from any kinds of programs that are likely to be helpful to them. It's going to be a disruption in the services they're currently receiving, and it's just a totally different track. The way most courts have dealt with this is to rely on the fact that the law assumes someone is competent until shown otherwise. So if they can get them into mental health court on an agreement from the participant and his or her attorney before the question of competency is raised, you can avoid this sort of sideline procedures. And, of course, competency restoration isn't about making you better in the community or reducing recidivism. It's about telling you what the court's all about. It's a civics lesson. It just seems to be beside the point for most of these people.
Thank you, Professor Wales. Dr. Callahan, the next question is for you. A participant writes, you stated that 67% of the people in mental health courts have substance use disorders. Which of these courts have been able to successfully implement integrated co-occurring substance abuse and mental health treatments?
I don't know if you'll be able to clarify if which specific courts or whether mental health courts or drug courts have more effectively incorporated integrated treatment.
It says people in mental health courts who have the co-occurring disorder.
There are a number of courts that have very effectively integrated co-occurring treatment into their court. In fact, there are about 9 adult mental health courts that don't even call themselves a mental health court. They just call themselves a co-occurring court because they recognize that the majority of the people who are on their docket actually have a co-occurring disorder. And for example, through the Gain Center, we do a lot with providing technical assistance around co-occurring disorder. The NADCP is going to release any minute, and we'll have it on the Gain Center website, a document that both CSG and the Gain Center have been involved in looking at co-occurring disorder in drug courts and what drug courts need to take into account when they have people with co-occurring disorder. But I think the more mature courts recognize co-occurring disorder is prevalent in most of their clients and have referred them to appropriate treatment. And just as a aside to that, it's also really important if someone has co-occurring disorder to screen them for trauma and refer them to trauma-specific services. The Queens, New York treatment courts have 3 specific programs, trauma programs, that they refer clients to who screen for elevated trauma experiences. So there's definitely a lot of good work being done around co-occurring disorder. I mention it in tandem with trauma because they tend to coexist. It's such a high frequency.
Great. Thank you both, Dr. Callahan and Professor Wales. We're going to move the presentation along. We prepared a list of research that was presented by Dr. Callahan and Professor Wales in our webinar today. We will make the webinar available online at consensusproject.org for download, where you'll be able to definitely find more information about the studies that were presented today. There are a couple other resources available if you would like more information related to mental health courts. The first is the Developing a Mental Health Court Curriculum, an interdisciplinary curriculum. The Bureau of Justice Assistance and the Council of State Governments Justice Center released the first single resource where you can find information that you need to plan, implement, and sustain a mental health court program in your jurisdiction. This resource is free, online, a flexible series of engaging and comprehensive presentation and activities for individuals or interdisciplinary groups. Developing a mental health court can be a useful tool for a number of different criminal justice and behavioral health professionals. The curriculum is available in freestanding modules and is easily customized for users' particular needs and at the time. I would also like to draw your attention to this list of recent research that expands on mental health courts. All of these studies were published in 2013. Like I said earlier, we will make this presentation available online at consensusproject.org, where you can download the presentation and find more information related to this list of research. And the next is the CSG Justice Center's Criminal Justice and Mental Health Consensus Project. It's coordinated by the Council of State Governments Justice Center, and it's an unprecedented national effort to help local, state, and federal policymakers and criminal justice and mental health professionals improve the responses to people with mental illnesses who come in contact with the criminal justice system. Since the publication of the landmark Consensus Project report in 2002, written by Justice Center staff and representatives of leading criminal staff working on the Consensus Project have supported the implementation of practical, flexible criminal justice mental health strategies through on-site technical assistance, the dissemination of information about programs, research, and policy developments in the field, continued development of policy recommendations, and educational presentations. In partnership with the Department of Justice and the Bureau of Justice Assistance, we have created 11 national learning sites, 5 which are mental health court sites, and 6 law enforcement jurisdictions, one of the largest interactive and fully searchable online databases of collaborative criminal justice and mental health programs from across the country, as well as a number of specialized publications on courts, corrections, law enforcement, and other mental health topics. You can sign up for our monthly newsletter at our website, www.consensusproject.org. And this concludes our webinar on Mental Health Courts Research Roundup, Applying Research to Practice. Thank you all for your attendance and participation. Thank you to the Bureau of Justice Assistance for supporting this event. And a big thank you to our presenters, Dr. Lisa Callahan and Professor Heathcote Wales. A recording of this presentation will be available online early next week on our website, which is www.consensusproject.org. Finally, when you leave this event, a brief survey on this webinar will pop up on your screen, and we would very much appreciate your feedback. Thank you, and we hope to see you again soon.